Morning, everybody. Hope everybody's doing well. This is our last cardiovascular and pulmonary pathology lecture for the second week of the quarter spring of 2020. Off we go. So this is where we left off. We were talking about thrombosis, and now we've come to a very common cause of thrombosis or thrombophilia, and that is the factor V Leiden mutation. Stars are overflowing everywhere. I don't know how else I can emphasize the importance of this topic. So it also has an AKA. You could see it on boards as factor V Leiden mutation. You could see it as activated protein C resistance. So what is it? Factor V Leiden mutation is a very common cause of thrombophilia or venous thrombophilia. You usually don't say venous thrombophilia. It's understood that when you say thrombophilius, it's understood that it's coming from the vein. Arteries, they can develop thrombus, deadly thrombus, but it doesn't happen that often, and that would definitely be stated arterial thrombophilia. So it's found in about 4% of the world population, so this is like a big problem, right? This is not Marfan syndrome. And I'm just writing down my time so I don't go cuckoo here on this. So folks who have it are said to be in a hypercoagulable state, or they're said to be thrombophiliacs. If they really specifically, you could say they have factor V Leiden thrombophilia. And hypercoagulable state just means because of a blood clotting condition, they tend to form thrombus. So we'll look at Virchow's triad here in a little bit, and I'll show you what I mean by that. Epidemiology for factor V Leiden mutation. So it's seen in about 0.1% of the population, which is fairly big. It is the most common genetic risk factor for the development of venous thromboembolism. Okay, and that means embolism. We'll get to that in a minute, but thrombo means thrombosis in a deep vein vessel. When you see embolism, that means a piece of the thrombus has broke loose and flew the coop, so to speak. I think we've showed you this before, but here's, let's say, a vessel goes on and on. Here's the lungs, or one of the lungs. So if you have thrombus, it's like a blood clot, right? Although we technically shouldn't say a blood clot, but everybody does. So there's a blood clots are on the outside of a vessel, but there's thrombus formation. So the danger of this is a piece of it breaks loose, and it goes, there's the heart. It goes through the heart, and it gets stuck somewhere in the pulmonary artery circulation of the lung. And if it stops just right, any piece of lung tissue that artery supplied is going to die. All right, and it's a little more complicated. You get a beaver dam, and it compresses the adjacent artery, and the adjacent artery is actually what causes the death of tissue. But all right, and we'll look at that more as we go. So most common genetic risk factor for the formation of a venous thromboembolism. The testing for factor V Leiden after somebody comes in the ER and they found out to have a big blood clot in their leg, after they get that clot under control and whittled away, one of the first tests they order is a molecular genetic test, or to find out if they have factor V Leiden or not. I've had several students who've come through the program have had it, so it's definitely out there. It's the most common cause of acute thromboembolism. Okay. That's a little arguable. That it's definitely the top two for sure. But it's found to be the cause of about 25% of those who suffer venous thromboembolism. So about 25% of the patients tested who come into the ER test will come back positive for the factor V Leiden mutation. The other top two, and these go back and forth, is kind of a newcomer, but this one is an acquired condition. This is antiphospholipid antibody syndrome, and we have slides coming on that. But that counts for 20%. But these two, I mean, studies are flipping back and forth. These two are very common, both of them. Now, factor V Leiden mutation, that's a congenital from birth problem. But antiphospholipid antibody syndrome, you develop that. You're not born with that. We'll talk about that here in a bit. So population prevalence throughout the world. So this is the another prevalence study. You can see studies are all over the map. But in the Americas, 5% of Americans have factor V Leiden. And amongst white people, Hispanics 2%, African Americans 1%. Look at Asians, 0.45%. So it's quite a genetic beast here. It really targets white people. And what the heck is a factor V and activated? What does all this stuff mean? We better explain what this means. You've got to remember your hematology here. So activated protein C, or APC, that is a turner offer. In fact, that is the major regulator or shutter downer of the blood clotting cascade. It turns off the cascade when it's no longer needed. Specifically, it regulates by binding to coagulation factor V and shutting it off. So APC binds to factor V, which is a powerful coagulation factor, and shuts it down. So if factor V is shut down, amongst other things, one step, you don't produce thrombin anymore. Thrombin is like flypaper, right? Factor V, very powerful procoagulant protein, right? Procoagulant means it clots the blood like crazy. It usually forms fibrin, which clots the blood like crazy. That's what actually clots it like crazy. Factor V just makes fibrin. APC also binds to and shuts off factor VIII, so that's another important factor. It's usually, so what's the problem then? The factor V, what is the factor V Leiden mutation? It's a single point mutation in the gene that makes factor V. So factor V Leiden mutation is a screwed up factor V. And what's the exact point mutation? I had explained what a point mutation is, but I'm going to let other people do that because I just don't have enough time these days. But I assume you know what a point mutation is. Google it, and there's plenty of YouTube videos on it. But the point mutation is the arginine is replaced by a glutamic acid or a glutamine molecule. All right, so this mutation, the factor V Leiden mutation, causes the production or the transcription, translation, central dogma of a screwed up factor V. Can we be more specific? What exactly is wrong with factor V? Well, the mutation gives rise to a factor V binding site malformation, and APC binds to factor V, and that's how it shuts down factor V. But if the binding site for factor V is screwed up, then APC can't bind to factor V, and it just goes on clotting and clotting and clotting. It eventually will turn off, but it's about 10 times slower than normal shutting down. So you're at great risk for over-clotting when something occurs, or clotting when you're not supposed to clot. Right? Everybody good with that? So dysfunctional factor V binding site. The binding site for factor V is screwed up. Here's factor V, and here its normal binding site is. And here comes APC. Guess I could have made that another color. But this guy is doing its job, clotting blood like crazy. But APC comes and binds to it right here. And we won't get into the mechanism, but that shuts down, that turns this guy off. And so that's the end of the blood clotting cascade. But if you have a factor V let's see, let's get that out of the way. That's kind of annoying how it does that. But let's draw another factor 5. Now this one has the factor 5 Leiden mutation. This one's mutated. So here comes APC trying to shut this guy off. This guy is clotting like crazy. And this guy comes to bind, and it can't bind because the binding site is screwed up, right? So that is the factor 5 Leiden mutation right there, right? It's a binding site mutation. Everybody good with that? Pretty simple. Those affected, therefore, are always at risk for thrombus formation, right? Especially for forming venous thromboemboli and venous thrombi and venous thromboemboli. It's kind of the same thing. Thrombus formation. If you have thrombus formation, you're at risk for it breaking off and becoming an emboli. So these people with factor 5 Leiden mutation, they have a hypercoagulable state. All right, what are the chances for developing a venous thromboembolism that goes all the way into the lungs? It's increased by a factor of 8 in people who are heterozygous for the condition. That means either mom's gene or dad's gene. Remember, everybody's got 2 genes. There's only one factor 5 mutated gene. People are in big trouble if mom and dad, they both gave them the mutated gene. They're 100% at risk, or 100 times above the average person at risk for clotting. They will clot at some time in their life. Okay, venous versus arterial thromboembolism. So all of these factors that we're talking about, factor 8 and factor 5 Leiden mutation, anti-lipoprotein antibody syndrome, these guys really cause venous thrombosis. Now you would think that why not cause arterial thrombosis? Well, first of all, the artery blood flow is much faster, so it discourages blood clotting to begin with. But it seems there's something more that is going on here. They believe that arterial blood clotting cascade and the venous blood clotting cascade are actually different. Even though you learn them as one, probably some differences because people with factor 5 Leiden, they don't have, some studies show there's not an increased risk for arterial clotting, which you wouldn't expect, although there are other studies that kind of show that's not true. So it's a little controversial, but it really looks like there's 2 different clotting pathways. And the clotting pathway is so darn complicated. We're still discovering to this day new factors involved in that, so it wouldn't surprise me. Now a hematoma, we'll do some definitions. I think we did this already. But this is a blood clot that forms outside of a blood vessel or within the tunica media. Hematoma does not form in the lumen of a blood vessel, right? Thrombus forms within the lumen, not a hematoma technically. Deep vein or deep venous thrombosis, this is a DVT. This is a preferred word. If you see a board question, it'll probably say deep vein thrombosis. This refers to a thrombus formation on the lumen of one of the deep vessels of the lower extremities. Not to be confused with superficial venous thrombosis. Well, that's like a blood clot that formed in the saphenous system. But the deep system is the more dangerous system because that's how blood gets back to the heart, to the deep system. Most of the blood. It could occur via the upper extremity veins, but it's pretty rare. Superficial venous thrombosis, as I just said, it's an occlusive thrombus formation of the superficial venous system of the lower extremities, or it could be the upper extremities. But that's pretty unusual, unless they have thoracic outlet syndrome. And again, we'll look at the systems in a bit. But these are not nearly as dangerous as a deep system thrombosis or an arterial thrombosis is dangerous anywhere, especially from the left heart, left atrium. These, if you do develop a thrombus and a piece breaks loose, because the flow of blood is usually into the deep system, from the superficial system into the deep system, The clot usually gets stuck in the in-between vessels called the perforators. Therefore, the body can eventually absorb it, and it's not that big of a problem. It can still cause severe swelling of the affected extremity, though. And here's a review from your anatomy days of the venous system of the lower extremities. So we have the skin up here, the epidermis. There are two, actually let's jump over. There are two venous systems in the dermis. It's very venous rich to drain all the skin, drain all the capillaries in here. So there's the subpapillary venous plexus and the reticular venous plexus. But bottom line is it comes out of the dermis through these pipes, and it connects into the superficial system like the saphenous vein or saphenous tributary. Okay, so this is called the reticular system, these pipes that connect the dermal venous blood to the superficial venous blood, like the saphenous or the short saphenous or any of its tributaries. About 85% of the blood from the saphenous system or superficial system is, I'm sorry, these are called reticular. Did I call them perforators? These are reticular vessels here. Reticular vessels dump into the superficial system. Superficial system dumps by the perforators into the deep system. And therefore, you can see the deep system is embedded in muscle. So if you're standing and swaying and walking, it's squirting this blood like a little peripheral heart out of the lower extremities, especially the soleus muscle. So that's kind of the flow of it. And here's a little simpler cartoon where the dermal venous system dumps into the superficial system. There's a reticular, these are the reticular veins. And then from there, it dumps into the deep system through the perforator veins. All right, so there they are, the four systems again. I just explained these. Again, the superficial system, 85% of the blood that's dumped from the reticular system into the superficial system, 85% of that blood is actually dumped into the deep system. We still get 15% of it can actually leave and go into the common femoral vein and go that way, but most of it comes from the deep, from the femoral vein. Right, think everything I said there. All right, let's go back to our definitions. Venous thromboembolism, said that one already, didn't we? Thromboembolism, venous means, if it just says thromboembolism, assume that it means venous thromboembolism. So venous thromboembolism is an embolism. It's a chunk of blood, like I drew, a chunk of thrombus that broke off the main body, and it's traveled up and it's got stuck somewhere, hopefully not in the heart, usually somewhere in the lung. And yep, it's understood that it comes from the lower system. Pulmonary venous thrombosis or pulmonary venous thromboemboli. That just tells you that, okay, the embolism, where did it get stuck? It didn't get stuck in the heart, it got stuck in the lungs. And when you say embolism, it's kind of understood that they end up in the lungs and that it's venous. The other types of aneurysms or embolisms that get stuck, they're rare, so it's kind of understood. You're not going to see this pulmonary venous thromboembolism. You'll just say thromboembolism, and you assume it came from the deep veins. If it came from the subclavian vein, which it can, especially in cancer patients, or the jugular vein, they'll definitely say that because that's more rare, but those are really dangerous if they get stuck there. Or if they get stuck, if they come from there. It's so close to the lungs. It could get stuck in the heart too. What's the incidence of deep vein thrombosis? Well, because so much of it is asymptomatic, we're not 100% sure. But there's a famous autopsy study that looked at the prevalence of DVT and pulmonary embolism in a group of terminally ill, basically patients. They're hospitalized for at least 2 weeks, some of them much longer. And after they died, they took them down and did an autopsy. And they found, surprisingly, and none of these people, the exclusion were none of these could have any known weren't hemophiliacs. They could not clot. They didn't have factor V Leiden. They didn't have antiphospholipid antibody syndrome. They didn't have factor VIII syndrome, any of the clotting. And they never had a DVT before in their life. So those people were thrown out of the study. These are people who without any expectation to clot. And the study found 30%, almost a third of the patients had either a DVT or no, they had deep vein thrombosis, 30%, and some of that 30% even had pulmonary embolism. So the part of the DVT was found, a chunk of it was found in the lungs as well. So bottom line of this study, being in the hospital, prolonged bed rest, laying there doing nothing is a huge risk factor for the developments. Even if you don't have any known clotting factor, that's not a good time. You got to keep moving. According to the Department of Health and Human Services, about 35,000 people are hospitalized in the United States each year. So that brings the annual incidence of hospitalization from one of these, from just a DVT, because it can cause horrible pain in your leg too. So that would drive you. It doesn't always embolize, or doesn't always end up in the lungs. So yeah, that's about 350,000 of these things. They happen to famous people too. Serena Williams in 2011 had a foot surgery, and then she was on a long airplane ride and had pain in her leg and ended up in the hospital for DVT. So it can definitely happen. What are some predisposing factors for DVT? One you always worry about is cancer. Some 40-year-old, 45-year-old, even 25-year-old testicular cancer. Out of the blue, they get a DVT. And they go to the hospital, put on heparin, and they're treated. No big deal. But the concern immediately becomes what caused that to clot. So they start testing for factor V mutation. They start factor V Leiden mutation, factor VIII mutation. Some of the common ones, antiphospholipid antibody syndrome is tested for. A lot of the tests come back normal. You got to start looking for cancer. Testicular cancer, prostate cancer if they're older, lung cancer, because that's often the first sign of cancer is the formation of a DVT. Other predisposing factors, as we said, long immobilization like in a hospital. Even worse than in a hospital is a long airplane ride, because the cabin of the airplane is about pressurized to about 8,000, like an atmosphere of 8,000. It's not a ground level atmosphere. It's about 8,000 feet, the same as Vail, Colorado. And yeah, smoking and pregnancy, obesity are risk factors. I don't think they're gigantic risk factors. Heart failure is a risk factor that slows the flow of blood down. And just getting old, kind of you lose ejection fraction as you get old. It's a risk factor as well. Some more risk factors, oral steroids. God, I keep forgetting to add testosterone therapy. I say that every year. I'm going to slide 239, add testosterone therapy. Yeah, people with factor V Leiden, you know how guys, they get old and they lose their testosterone and they want to get a testosterone boost when you get in your 50s, 60s, 70s or so. If you have factor V Leiden, if you have any of those conditions, you cannot have, or you should not have, testosterone, because that greatly increases the risk. Just like other steroids, like estrogen replacement therapy can do it. Major trauma, especially surgeries. This is kind of the star of this slide for right now, but surgeries, especially hip and knee surgery, are quite dangerous. It stimulates the epithelial cell damage from all the blood vessels getting cut. They release prothrombogenic molecules. Those endothelial cells get mad, and it can cause big blood clots in the area, and they can break loose. Case in point, really great talk show, probably one of the best talk show hosts, I believe, Pete Wilson. Very right down the middle of the road, not too left, not too right, really told it like it was. I think he was Hall of Fame too. But yeah, he was Friday on the show. Okay, going in for a simple hip replacement surgery. Okay, great. We'll see you in a couple of weeks. Never came back. About 6 weeks later, they announced he died from a DVT that got into the pulmonary, got stuck in the heart and killed him. So yeah, it's out there. Here's the top 5 causes according to one really reputable source, although it's a little old, 2014. But number 1, and I wouldn't know these top few of these things. I definitely tend to formulate a question around these. So on the acquired side, the antiphospholipid antibody syndrome, and that out of all of them, that's the number 1 risk factor for the development of thrombosis. Number 2, very close together. In some studies, here's a 2020 study that shows factor 5 did beat APAS, antiphospholipid antibody syndrome, in this study. So they're really neck and neck. But you definitely want to know antiphospholipid antibody syndrome. And then factor 5 Leiden. See, in this one, it's calling it activated protein C resistance. I have a feeling that's how it'll show up on boards, but who knows? Another one is the prothrombin gene mutation. There's a protein C deficiency and a protein S deficiency. Oh, those aren't even, let's not worry about those. Then there's a hyperhomocystinemia. It's number 4. Number 5. Number 4 is an elevated factor 8 activity. So those top 5, you should definitely be familiar, be able to pick one of those out. All right, so we've talked a lot about it. It looks like it's the new champ, but it's almost dethroned the old champ, factor 5 Leiden. What's the deal with this antiphospholipid antibody syndrome, APAS? It's number 1 cause, according to the NIH, the number 1 cause of acquired. It is, disputedly. There's no other one close to this. Whether or not it's the number 1 cause of thrombophilia in general, it's very close between it and factor 5 Leiden. But with regard to the acquired, develop these over time, it's number 1. And there are antiphospholipid antibodies. There's a test for this. You can see if you have them. And when I say phospholipid, what's the first thing that pops in your mind? Cell membrane, right? It's a phospholipid bilayer. And so endothelial cells, they have a cell membrane, right? Yeah. And so they're the target of an autoimmune attack against by the body. So found in about 20% of patients struck down by VTEs. Okay, whether 20 or 25. Okay, I've talked enough about the neck and neck race between those two. But what is this darn thing? It's an autoimmune disorder. So it's an acquired autoimmune disorder where antibodies attack the phospholipids of your body, and they love the phospholipids of the veins for whatever reason more than anything else. So these antibodies love the endothelial lining. I just said that. Considered by some authors the number 1 risk for the development of thromboemboli. Okay, again, we're going down that hole. Isn't this the same slide? I don't know. So what else does antilipid or antiphospholipid antibody syndrome do? It also increases the risk for pregnancy complications. And not just, for the big one, right, is preeclampsia. Which can kill you. It's a super high, uncontrollable hypertension and miscarriage. So it affects pregnant people as well, have to watch out for this thing. And there's the lipid bilayer of, we could say this is just an endothelial cell of the popliteal vein. We've been picking on that one lately. But yeah, so antibodies attack. The question we don't know is, why can you go through your whole life and you don't get an attack against your deep vessel endothelial cells, and then all of a sudden you turn 30 or 40, all of a sudden you attack? So there's a lot of factors. Smoking is one, that cigarette particles get inside the DNA, get into the cell, get into the DNA here, and manipulate some of the genes. That you turn on some genes that aren't supposed to be turned on. It gives the endothelial cell a new look. Maybe it doesn't affect its function, but it has a new look to it, some new proteins floating in its cell membrane. And all of a sudden the body goes, who are you? You're different. I don't like you. And an attack occurs. I mean, that's the standard answer for a lot of autoimmune type attacks. There's a phospholipid if you don't good for biochemistry review. I've asked this just out of the blue before, just to keep you up with your biochem. You got boards coming up soon. So we have a choline hooked to a phosphate. We have a glycerol, and then we have 2 fatty acids for the tail. So that's your run-of-the-mill phospholipid. The autoimmune, we said this, autoimmune attack, it hits the epithelial cells of veins usually and causes an inflammation. And then we've already said when endothelial cells get irritated, or maybe I haven't said it yet, but when endothelial cells get irritated by inflammation, they respond by secreting stuff they're not supposed to secrete, like the like von Willebrand factor. I didn't put that in there, but they also, more importantly, they stop secreting the slippery 3. Remember prostacyclin 2, PGI2, tissue plasminogen activator, TPA, thrombomodulin. They stop secreting those dudes, and now you're super sticky in the area, so platelets can stick really, really easy. So that's kind of the deal with antiphospholipid antibody syndrome. So back to DVTs in general, what are the genetic risk factors? Well, genetic risk factors in general count for about 60% of developing DVT, according to twin studies. Factor V Leiden mutation is by far the biggest genetic risk factor. And remember, phospholipid antibody syndrome doesn't come in this. It's not a genetic condition, at least not yet. It's relatively new. We're still studying, but so far it's acquired. Some more definitions. Boards love these definitions. Oh, here's some old school definitions they're trying to get rid of, but they're still going to be on boards, I bet. So both of these, thrombophilebitis and phlebothrombosis, have been around since the 80s when I was in school. I remember learning these. They're really old terminology. Medical texts don't even talk about them anymore. Rubens, one of the chiropractic board pathology books, even he says this is old terminology and it's been replaced. But nevertheless, Robbins talks about them, so I better put them in there because they could show up. They're both board books. They could show up on boards. So let's go through them. And this is the one that doesn't make sense. Thromboplebitis. What does itis mean? Inflammation. So this means that the blood vessel has to be already inflamed, so you get some type of inflammation going on in the blood vessel. The problem with this is there's so many inflammatory conditions. So everybody has inflamed blood vessels. Most people over 50 have at least some atherosclerosis. That's an inflammatory process. So it's just overreaching. But nevertheless, the definition states that you have a pre-existing endothelial inflammation, and then thrombus occurs, or clotting occurs, on top of that background of inflammation. Okay? And in reality, I mean, when they go in there and they look, oftentimes there's no inflammation even found, but we'll just stay with the theme of getting us through this. So phlebothrombosis, it can occur in any part of the venous system. It's typically associated with some inflammatory disorders then. So vessel trauma can cause inflammation. Vasculitis, there's about 50 different vasculitises that I took all those out because we just don't have time. I mean, I could make the whole quarter all about pathology of the cardiovascular system, or just the vascular system. But I cut it off. Once we come to the midterms, that's it. We're moving on to the heart. I could make the whole quarter just about the heart. I could make the whole quarter just about the lungs. There's so many pathologies. But anyway, so vasculitis, infection, atherosclerosis, this is a pre-existing inflammatory process. Berger's disease we'll talk about. And then, of course, this one, it's not in Robbins. It's relatively new, but it will be the next edition, I bet, Rubens and Robbins. Antiphospholipid antibody syndrome must be added to this list. Okay, now we have phlebothrombosis. So the AKA, and Rubin and Robbins both agree, which is amazing on something. Phlebothrombosis is an AKA for DVT. So the word deep vein thrombosis is now preferred to phlebothrombosis or thrombophilis. We don't use those terms anymore. We use deep vein thrombosis instead. Okay. Venous thrombus formation within a member. So this is, if we go back to this is thrombosis occurs on a vessel that is not inflamed. It had no pre-existing inflammation, which is ridiculous because almost everybody does have some inflammation. So DVT, it doesn't care. You can have inflammation, you cannot have inflammation. In the modern definition of DVT, it's just thrombosis, and it doesn't care what the background was. We got rid of this background of inflammation versus background of non-inflammation. See how that works? All right, we should talk about casting. This is really dangerous. Untreated deep vein thrombosis may result in accumulation of these really long casts. So let's get some drawing going here. So we've been picking on the popliteal vein. So here's the popliteal vein. Okay, it becomes the femoral vein. And then it becomes the common femoral vein. That's right. There's a common femoral vein. There's the deep femoral vein here. There's the saphenous vein coming. This little junction here, this is called the SFO, saphenofemoral junction. But here's the popliteal vein. So we get a thrombus forming here. I'll just make it easy. Maybe it's not that bad. That's completely occlusive. That's a problem. But casting is, with the passage of time, and this thing's going to hurt in most people, it doesn't break loose, but instead it starts casting downstream. And that's the deal with it there. Can get the longer this gets, the more dangerous it gets. This can go all the way up into, there's the common, now it's in the common femoral vein. It can go into the external iliac, there's the inguinal ligament. Right, now it's in the external ligament. Super, super dangerous. These kill people so much. It can even go up into the common iliac. But that is called casting. And not only will that clog all the pipes, your whole leg is going to be red and swollen with something like this. Can you imagine if big chunks of this start breaking loose? These kill people. A lot of times they don't make it through the heart. They get stuck in the heart. We'll look at satellite embolisms here in a minute. If they make it through the heart, they bomb the lungs with sometimes hundreds of pieces of emboli formation. And it can destroy the lungs if it's bad enough, and it kill you. So that's called casting. Very, very dangerous. Okay, those are luminal casts. Super dangerous. Okay, there's a condition. I took all these slides out because I think it's beyond the scope of chiropractic boards. You medical people probably better look up phlegmasia cerulean dolens. Cerulean, or AKAs. This is that casting. There's actually another type of casting that's not quite as bad. But this clogs up the superficial system, starts in the deep system, it clogs up the perforators, clogs up the superficial system. Patient, why he waited so long, who knows why he waited so long, but everything is just backed up. Giant beaver dam, no arterial blood can get out. Arteries, no problem. Arteries are still pumping blood in here, but it can't get out. And so he's just like that picture I drew. So very, very dangerous. Phlegmasia cerulean dolens. That's all I'll say. I used to have a bunch of slides, but I think I have an old video about thrombus on YouTube that might actually explain that. All right, now the concept of Virchow's triad. I can almost guarantee you, I just took a bunch of stars out because I'm also, you guys don't know a little background information. All my slides were not these extra wide slides. They were those skinny slides for our school's PowerPoints or our school's projecting systems. So I just had to transfer all of these and make them all bigger. So I had to knock off a bunch of stars to make this fit as I stretched it out. So let me tell you, there is a lot of stars on this slide. There should be, because a Virchow's triad question will be, you can't miss that question. But there's a virtual triad, or there's a triad of risk factors that when you have all three, you're going to probably get a blood clot. And let's go through those three. And it's not that hard to get this triad, like this first box. So you need to tick 3 boxes to make the triad. This one's easy to tick. So you can have endothelial wall injury from an accident you were in, or maybe some autoimmune disease, tacking a vessel, Berger's disease. Okay, so if that doesn't work, any chronic inflammatory condition ticks the box, like atherosclerosis or hypertension, hypercholesterolemia, cigarette smoking. So it's really very easy to tick this box. So almost everybody's box is ticked on this one. This is the one where everybody's box isn't ticked. Although, if you're a normal human walking around, you've probably never been tested for any of these hypercoagulable states, like antiphospholipid antibody syndrome, factor V Leiden, factor VIII, the whole gang, or cancer. Any hypercoagulable state ticks the box. That's the harder one to tick. And then sluggish. So people with factor V Leiden, they're probably going to have one of these, probably have hypertension or atherosclerosis. They're probably always going to have 2 boxes ticked. But what gets them is this one, the sluggish blood flow. And it's usually this one right here, airline flight. They don't know they have the other 2 boxes ticked, and they get on an airplane flight without compression stockings. Compression stockings can save people's lives. They're really, really important. We'll talk about them again. I know I talked about them once, but we'll show you a study on these things, a Cochrane study, which is very trustworthy. So any venous stasis, if you have heart failure, if you have cirrhosis, any beaver dam, aortic valve stenosis, anything that makes the blood go slow ticks this box. Bed rest, you're in the hospital, AFib, anything that, if you have AFibs, some of the ejection fraction may be screwed up a little bit. And plus you have non-laminar blood flow, sluggish blood flow you can get an arterial embolism, which is really dangerous because it can go up in the brain, cause a stroke. So it's bottom line is if you have, this is the hardest box to check, the hypercoagulable state. You're going to have to do some testing to find out. But if that box is checked, then it's not too hard to check the other boxes. What's the net? What if you get a DVT? What happens? You don't go to the hospital. What happens to it? There's 3 fates of it, depending on how big it is. The body can definitely destroy these things if it's not too big by itself. The body has enzymes that go in there and chew these things up. But it doesn't always get chewed up. Sometimes they can reorganize and morph into the blood vessel wall, and it becomes like a scar on the blood vessel wall. It'll never embolize. You don't have to worry about that. But nevertheless, you'll always have decreased flow through that vessel, and you're going to have increased pressure in your lower extremities from the decreased flow. It might even be completely knocked out, completely occluded, and you can easily live your life like that. But you're going to have problems down in the gator area. You probably develop some brawny indurations, as we talked about, telangiectasia, some swelling down there. Some of them, the ones especially that completely occlude the lumen, a hole forms. It's like lysis occurs, but in a hole. So it makes like a new channel for them. They should have added, this is out of Robbins, they should have added that sometimes if it is completely clotted, like an organization where it clots the vessel, you can definitely grow new blood vessels around it. So let's go back to our popliteal vein here. All right, let's say this guy lost his popliteal vein. Popliteal veins are often doubles, so there's usually another one. Not usually, but there can be another one, so that wouldn't be a problem. But if this is your only one, the body is so smart, it can actually grow new blood vessels within about 6 weeks, to my understanding. It can grow new blood vessels. They're not as big as the original, but it can definitely grow new blood vessels around the clot, several of them. So body is really smart, and it can grow new veins. which is a good thing, but it might be a bad thing if you get this. I'll wait till we get there. Oh, yeah, I'll wait. All right, so that could be added to that. And then we just learned that you can get casting, and it can cast very, very dangerous, right? And then embolization, maybe the whole thing will break loose and go up and get stuck in the lungs and cause all sorts of trouble. So there's a little cartoon of the thrombus formation. They usually form right around the valves too. They wreck the valves. That's why people have chronic venous insufficiency after, because their valves are wrecked and they can't get blood out of the deep system. All right, let's talk about these emboli some more. We've talked a little bit. Let's really dig into these things. Let me see. How are we doing? Where are we at on time here? Don't want to bomb you guys. Just like the slide. Bomb you guys with too much information. Oh, we're fine. So an embolism is any substance. Doesn't have to be thrombus. Drug users used to get, they use those little cotton balls, and you could get, and baby powder, they could get like talc emboli. They're air emboli. Took all those slides out. We don't have time for all that stuff. But there's other things that can travel. But an embolus, from our perspective, it's thrombus that's broken loose, and it's traveling downstream. Sometimes I put upstream and people get that question wrong. Remember the flow direction. It travels downstream or distally. And it gets stuck. It usually gets stuck in a vessel that is about the same diameter as it is. And it could kind of get stuck. So some blood usually gets stuck where some blood goes through. If you're unlucky, it may fit really nicely and completely stop that blood downstream, which is going to cause ischemia. Not from the vessel, because it's a vein, right? So the vein is heading for the microcirculation. The trouble is the backup swells up and it compresses some of the bronchial arteries, and that's what causes the ischemia. So most common type of emboli is a venous thromboemboli, right? It comes from upstream thrombus formation, usually in the deep veins of the lower extremity. You got to know your deep veins, right? So we have posterior tibial, remember these? Perineal vein, they come together to form the popliteal vein. The popliteal vein leaves the popliteal fossa, goes into the anterior compartment of the thigh, just changes names, to the femoral vein. Deep femoral vein does not cross into the lower limbs. It kind of branches out and supplies different muscles. It ends itself in the thigh. But yeah, these are the deep system. The common femoral vein is not really a member of the deep system. That's the iliofemoral system. Right, so here's everything we just talked about. Right, common femoral. So this is the iliofemoral system, starting right here at the common femoral. You can read those. Pulmonary emboli occurs when the emboli gets stuck, usually in a pulmonary artery. About 90% of these arise from the deep veins. They're called pulmonary thromboemboli, aka pulmonary venous thromboemboli, or just pulmonary emboli. Other sources of pulmonary thromboemboli, so right, 90%. What about the other 10? There's other venous systems that can let them loose. The big ones are and these are dangerous, really dangerous. You treat these really aggressively. The inferior superior vena cava, that goes into the heart to the lungs. The jugular veins. My wife's friend died of a DVT in the jugular vein and subclavian veins. And they broke loose and stuck in the heart. Upper extremities, there are veins up there. It's pretty rare unless you have thoracic outlet syndrome, which is a terrible name. But those of you who had me for anatomy, I'm sure I went on my rant about how that's not the correct name. That's the thoracic inlet, not really the thoracic outlet. But I try not to digress because I think we've had enough of CVP and GIGU for the week. This is the last lecture of that massive class. So symptoms of acute. So this is important. I could have even more stars. I had to get rid of stars as I stretched the slide out. So what are the symptoms of an acute pulmonary embolism? Well, if it's small, there might not be any symptoms. If they're medium in size, the size of maybe a pea or so, they can get stuck in the lungs, enough lung tissue to actually interfere with breathing. So you might get up and have a little bit of dyspnea, a little bit of tachypnea, and I could have added a little tachycardia. The heart might be beating to overcome from the lack of oxygen, and that's maybe your only sign, and may happen for a week, may happen for a couple days, maybe a day, and then maybe you didn't even realize that you had this. If they're big, though, they're size of a marble, like a regular 1 centimeter marble, they're going to cause trouble. They're going to eventually get stuck in pulmonary artery circulation somewhere, cause a beaver dam, and that, I should probably show you that. So there's the heart. There's pulmonary trunk. Yeah, it's good I show you this anyway, because we're going to look at a case of pulmonary trunk. What is this? Pulmonary vein or artery? It's going away from the heart. Must be pulmonary vein. Yeah. And then we go into the lungs. Here's not a very good lung. There's the lung. But we have a lot of other vessels, bronchial system. There's a lot of other blood, because the lung is tissue too. So we have a lot of other smaller blood vessels that are hanging out here and actually feeding the periphery or the parenchyma of the lungs. And those are important. So what happens if you get a DVT, a good size one? Well, let's say we get one right here. Some of you are already figuring this out. So if we get one right here, it decreases blood flow this way. So you've just lost some of your blood flow, but it stretches beaver dams like crazy up here. And I guess I could have drawn those a little better. But it pinches these arteries, right? So this artery is pinched here, and the blood beaver dams here. But anything downstream, any of the tissue this was feeding is going to become ischemic and die. Okay, so that's how that happens. That's called an infarct. When the tissue, let's see, do we have brown? I wonder. No, it's blue. How about green? Yeah, so all this tissue, this is lung tissue. Let's make our lung green. So all this lung tissue starts dying, and it can die and cause a horrible pleuritic chest pain when this dies. But that's kind of the mechanism behind that. All right, so if they're large, the symptoms are pleuritic chest pain. Like every time you take a breath, imagine anybody had fractured ribs. I've had fractured ribs, horrible pain with those things. Worse pain than fractured ribs. It's like sticking a knife in you every time you breathe. It's a horrible inspiration pain. That's pleuritic chest pain. So these are signs of a large or a medium to large. It means that a complete beaver dam has occurred. And so pleuritic chest pain. And you're probably going to get a lung infarct from this. And you could get a pleural effusion from the blood vessels leaking blood out into the interstitium and getting into the alveoli even. Dyspnea, you might have a dyspnea, trouble breathing, tachypnea, cyanosis, syncope. Maybe you're so bad that you're not getting enough blood oxygenized that's decreasing blood flow through the lungs, and you're starting to get dizzy. A cough, and like in a later phase, people tend to have a cough with these things. Pleuritic chest pain, it's also called pleurisy. Should have bolded that, AKA. But it's a stabbing-like pain or a catching pain when you breathe. Really strong pain. Typically occurs unilaterally on the side of the infarct. It usually means an infarct, and it's a medical emergency. You have to go to the ER with this thing. There's other causes of pleuritic chest pain. We'll look at that. Pericarditis is one, but we'll hit that when the time comes. What if casting occurred and a huge train of clot broke loose? It can be so big that it doesn't even make it into the lungs. It can get stuck in the pulmonary trunk, and that's called a saddle embolism. Right. Another thing, what about medium-size bombardments? You have some type of thrombophilia, you don't know it, and your lungs are getting bombed all the time. And every now and then you get shortness of breath, but you don't think anything of it. It can wreck the lungs. It can scar up the microcirculation, and that will make it hard for the right heart to drive blood through, and the right heart can fail. Remember, the right heart is a wimp. It's not designed to pump blood through the heart. So this causes slow onset pulmonary hypertension, and leads to right ventricular hypertrophy and later right heart failure. It's not considered cor pulmonale, though, because it didn't come from a lung disease in and of itself. And these patients, if they have a patent foramen ovale, they're at great risk for paradoxical embolism, which is where a venous embolism gets over into the arterial side of the heart, the left heart, and then it's like Russian roulette. Where does that bomb go? Does it go up in carotid artery, common carotid artery, go up into the brain, cause a stroke? Does it go back into the coronary artery, cause a heart attack? Does it go down and take out the celiac trunk? Maybe it goes all the way down to the dorsalis pedis artery, and it takes out part of your foot. So those are very dangerous. We'll talk about them when the time comes. Let's go back to saddle emboli here. So massive emboli that doesn't even make it to the lungs. It gets stuck in the heart. These guys are medical emergencies. So luckily, the percentage of the pie, 2 out of 100 will have a saddle embolism. They're very dangerous, though. Let's look at a real case here. 62-year-old came to the emergency department. Severe pleuritic chest pain. Had to put him on morphine. Actually, they put him on Dilantin. And dyspnea, couldn't breathe. So they got a history out of him. He just got back from a long Europe plane ride, 12 hours, with Australia or somewhere. And 3 days ago, and he also had a history of factor V Leiden that he remembered. And after that, he passed away. But before he passed away, they were able to get a CT scan of him just before he passed away. And so we have a CT and an autopsy of this guy. Here's a CT scan. I'll let you look at that for a second while I take some water. So it's a contrast-enhanced CT. So we have blood moving through the venous system. That's all the white. And we have and some of it's really white, some of it didn't fill up very good, but you can see, like here's the inferior vena cava going into the heart. Here's the pulmonary trunk. See a problem? You can see how nicely the tracheobronchial tree, or the bronchial tree, filled up really nice. All these bronchial arteries filled up great. Yeah, good. Some of you saw it. Where's the left pulmonary artery? I don't know. Here's the right. The left is gone. There's a huge piece of thrombus that's completely occluded this. There's no fill of lung. He completely lost his lung. And that was enough to kill him. Hypoxia, hypovolemic shock, or hypoxia. So at the autopsy, so here's the heart, again, the cartoon. There's the right atria. Right ventricle is here. Remember, the blood leaves through the pulmonary trunk. I just drew it. So if you split that open, butterfly it open, that's what they did here. And they butterflied these open. And yeah, that's a gigantic saddle embolism. That's a huge blood clot. So that's called a saddle embolism, and they're deadly. Okay, pulmonary infarct. So that means that the pulmonary embolus blocked an artery, as we described, kind of beaver dam situation, and it killed the lung tissue. So pulmonary infarct, it's not caused by the venous side, but it's caused from the beaver dam compressing adjacent blood vessels. Severe pleuritic chest pain with these things. Okay. So more clinical signs of an infarct: pleuritic chest pain, 10-10, dyspnea, shortness of breath, cough, hemoptysis. Some of that arterial blood is backing up and spilling into the alveoli, so you're coughing it up. Mild pleural effusion is common around the lungs. Could progress to an atelectasis, but I don't think that's the norm. Decreases surfactant as well. And it depends on the severity, but there is a decrease in vital capacity if you've lost some of your lung tissue. Increased work, we already said, can lead to right heart failure, because the right heart now has trouble pumping blood or pushing blood through that scarred up. After it heals up with scar tissue and everything, it's hard to push through there. Let's see what else here. Yep, and paradoxical embolism. I explained that already. We'll dig into that when the time comes. Let's do another case. 48-year-old, chronic low back pain for 6 weeks, unknown injury, history of some sort of bleeding disorder. A little bit of digging found out he had antiphospholipid antibody syndrome and hypercholesteremia. So you took some x-rays of this dude. He's got low back pain. What in the heck? Or what in the halibut, SpongeBob would say. What is that thing? Anybody see it? Looks like a badminton or a birdie that you play badminton with. Anybody know? Good, somebody got it. That's an IVC filter, inferior vena cava filter. So there's what they look like. You see these on the news, right? The lawyers advertising. Have you been damaged by a IVC filter? Call our office. Yeah, there's a problem with these things. But they can save your life, too. So patients with a history of severe thromboembolic disease may actually be given one of these filters. If they go into the hospital, they've had a pulmonary embolism and they still have a huge clot, they have a casting that's occurred, they may put one of these in temporarily to prevent more of that clot from going out. It's not intended to be permanent, although sometimes the tunica intima grows over this thing, and it can make it permanent. So it fits. Let's see. Let's see. There we go. Ooh, I thought it would crash for a second. I have my backup going, but we don't want to use that backup unless we have to. Got a camera filming my screen. So it goes in the inferior vena cava, kind of around just below the renal arteries. And if you get a big new piece of blood clot that breaks loose and it's heading toward the heart, it's going to get caught by this thing and rattle around and dissolve with the passage of time. What's the problem with these things? One big problem is that the body senses there's a restriction of blood flow and it grows new blood vessels around it. Kind of jumping ahead of my slides. And so kind of medium-sized clots can get around it by these new blood vessel growths. So it's made it to give the patient time to get their anticoagulation therapy dialed in, their Coumadin, get their INR levels dialed in. There's another one of these. Okay, so they'll catch medium, even relatively small, medium to large size emboli, or huge ones, they'll catch it all. And they prevent it from getting to the lungs and heart. They're typically removed about 6 to 12 weeks after the procedure, or after you've got your blood thin enough so clotting won't occur. Patients who fail anticoagulation therapy, they may have one of these stuck in there all the time, and that's their only way to stop repeated clotting. That's not ideal, though. There are complications, though. Tunica media can grow over it, making it almost impossible to get out. It can tip sideways, and therefore it's not as effective. Medium-sized clots can sneak by it. New veins can grow around it. Or it can break. The lawyers are advertising for ones that break. Hopefully the new designs are coming out to fix those problems. and a piece of metal can end up in your stab in your heart or end up in your lung somewhere. It's just another picture of that. Compression stockings, we talked about them before, how it's a graded compression. So we talked about all this stuff already. There are a must for long trips. You got to wear these things. They definitely work. How do we know? One of the strongest, best pieces of research, of course, I don't, you hadn't had Dr. Seuss's class yet, but a systematic review is a study of all the good studies, especially when it's done by the Cochrane database. I haven't heard many complaints about them. They don't accept funding from manufacturers. Like if you make a new IVC filter and you give them $100,000 to do a study, it's kind of quid pro quo kind of thing. I'll give you this great funding, and by the way, while you're doing the study, we'll make your salary about $1 million a year for the 3 years you're doing the study. So, but quid pro quo, you better make the study favor me. That doesn't fly with Cochrane. They don't do that sort of stuff, to my knowledge. So they took 11 randomized controlled trials, and they pooled all the patients together. So almost 3,000 patients that were studied in this Clark study, 2016. So it's not that old. Great study. So all of the patients in the study were half of the cohort wore compression stockings. The other half didn't wear compression stockings. Just run-of-the-mill people. Some of them might have had some of the clotting disorders, factor V Leiden, but it was just they didn't screen for any of that stuff. So that could be one confounder, but unlikely. A general sample of the population. They all had to go on plane rides at least 5 hours long. What did they find? It worked. Compression stockings work. So officially, quote, there's high-quality evidence that the airline passengers, similar to the ones in this review, can expect a substantial reduction in the incidence of symptomless DVT. Not a single person in the study after the airplane ride, and they were tested and ultrasounded for the presence of blood clots, not a single person had pain from these. So some people probably would have died from this big of a group. But they caught them all before they casted and got big. So they definitely work. All right, and we're getting near the end here. Let's talk just a little bit about the treatment for a DVT, deep vein thrombosis, and PE. Most of the people come in the ER, breathing troubles. They've had a PE, and they can treat the PE. Not much to do. Let the body reabsorb it or scar or whatever. But the problem is, where did it come from? And so they immediately do an ultrasound, and a lot of times it's been casted, and there's a big chunk of a thrombus waiting to break off again, and that's the emergency. So they're all started on heparin right away. That's the first step. And that's an anticoagulant. It doesn't dissolve the clot, though. But it stops the clot from growing, and it sticks the clot to the vessel wall, some evidence says. So it's unlikely that it'll break off. And then it's very powerful. You don't stay on heparin forever. You go over to a different type of clotting agent, warfarin, Coumadin, warfarin. Those are the ones that have been around forever. Those have an INR. You have to test your blood all the time to make sure, and you have to eat the same meal all the time, especially with vegetables. It's a vitamin K inhibitor. But yeah, the new ones, Predexa, Xarelto, Eliquis, you can eat whatever you want. These are a little shaky still. You can't turn them off right away if you're in a car accident and bleeding, although I think that problem is just about taken care of. I think most hospitals have antidotes to these now. These just came out like 2010, 11, 12 or so. So they're great because you don't have to stick yourself and get a blood work every week or every month to see what your INR level, how thin your blood is. But they're still new, so we're kind of waiting to see how these guys do. But what if your blood clot is really bad? If it's severe, it's casted, and then you're in a different camp. Then you need to have some type of thrombolytic procedure done. And there's two ways to do that. There's some medications like urokinase. There should be E there. I'm not familiar with this one. I think there should be 1A there. Alteplase, streptokinase is common one. Reitplase is another one. But these guys are clot breakers. So if the clot is big, you can't wait around for your body to try to break it down or for it to petrify and not be dangerous anymore. So there's also a catheter-based procedure where they stick a wire through the catheter and then they inject through the wire. They inject some of these medications right in to get the job done. Before these procedures are done, especially before the catheter procedures are done, they have to install an IVC filter to prevent. If they poke a wire in that clot, it could break loose, and there's got to be something there to catch it. All right, so that is the end of this week 2, and we will see you next week. Send me questions. I got a couple in my email, so after I get this rendered down, and then probably it's going to be slow right now until we get our internet fixed. But I'll get this up as soon as possible. See you next week. But send me questions if you have questions, and I'll get to those.